morning.
Good morning. Good morning. Sorry, he is in background. I try to just.
Oh, it's
Good
okay.
morning.
Good morning.
Yeah, we're just still getting started and organizing people. Richard is off getting his slides uploaded for his presentation in the next session, which is the joint IRPA ICRP task group session. So we have fewer than the usual people. Hopefully more people will join us. Our rapporteurs put together these slides. Hopefully you can see them. Can Iggy and Ahmed, can you see the slides?
Yes.
Excellent. So what these are the slides that have summarized some of the thoughts from yesterday. So we thought there are a couple things we want to do. One is we want to go through them because we just have an hour and a half to look at the summaries from yesterday, summaries and conclusions. So these, but before we look at our summaries and conclusions, we wanted to go through the questions that were sent from Group D. Group D. So those are the group that was supposed to join us but didn't. And last night you all saw, I think you saw, or at least some of us saw the questions sent from Group D. Okay. Good morning, Klaus.
Good morning.
So we're going to look at the questions sent from Group D to us. So
Okay.
let's go to the next.
You can use the pointer.
Okay.
Wonderful question.
Yes. Before we do that, thanks, Klaus, for your email about Shankar. We will talk about him.
Yeah.
I appreciate that. If you have other information, of course, that would be helpful so we can put it on the ICRP website.
Not yet, but I get in contact.
That would be good. That would be good.
Obviously, he was very much drawn back because he couldn't move very much. I talked to him about 8 weeks ago, but that was the last information I have.
Well, thank you. So, so the questions we have here are number one, is the all or nothing rule still valid for the pre-implantation phase? So remember the all or nothing phenomenon is that the threshold of
I think I have to go back. Usually I'm an old man and therefore I always talk about things which are very, very long ago. This was introduced into ICRP by Jakob. He was director at GSF at the time, and he explained it to me. And the explanation for this introduction of a so-called deterministic effect is based on a very simple idea. There are effects which are monoclonal single cell effects, and they by definition are stochastic. And there are multi-cell effects, which are by definition have a threshold. And as an example for the multi-cell effects, he described the acute radiation syndrome. And I think there's nobody who doubts that the acute radiation syndrome has a threshold. So this was so simple that ICRP immediately adopted the whole system of stochastic and deterministic. Now, everybody knows now that although there are clonal elements in carcinogenesis, it's certainly not a single cell effect. Moreover, there are multiple series of mutations in the pathogenesis. On the other hand, in particular the brain, was based on the early data on microcephaly. And this was described in the 70s when all this 50 years ago was developed, was the main argument for describing how radiation causes late normal tissue damage. And this is by decreasing cell production. Hypoplasia is what the term of the pathologists. So anything which is, if after radiation something is smaller, it's a reduced cell production. And this, by definition, is also a multi-cell effect and therefore has a threshold. Now, there is no evidence that reduced production of nerve cells is involved in the development of severe mental retardation. And all the data, for example, by Rafi and his predecessors, they all point to a signaling event where there is no clear evidence for a multi-cell effect, which many cells are killed. Cell killing doesn't play just such a role. Maybe there is some point in it. And therefore, the biological basis for the distinction is very shattered. So the all or nothing rule is based on 50-year-old concepts. And therefore, we shouldn't play this game anymore. So that's historical background. How did it develop? And the pre-implantation phase is, I think it is clear that there is an enormous regeneration capacity if there are 16 or 32 stem cells which are not really damaged. Nevertheless, to say that if one of these stem cells survives, then you have a normal development. But again, the development is not just a colony formation assay. That would be a colony would be a all or nothing. Even this in vitro process is not an all or nothing. There are small colonies, there are big colonies, there are colonies which have genomic instability, etc. So the all or nothing is also a oversimplification of the processes which go on. So that, sorry, that was a lecture for my students, but that's my way of doing it. Sorry.
That's all right. That's very helpful. You know, that takes us in a way, you know, simplification is what we need in the radiological protection scheme. We may simplify in order to have a way of communicating. So that's, you know, to me, that's fair up to as long as it's a reasonable simplification. So, but it does bring us to that second question, which is, you know, I remember that when I reviewed the you know, the publications that we have, that there was some animal evidence that that there are some malformations that can be that were made in the pre-implantation period. And so can you talk to that?
Yeah, I think this is very much based on the Streffer group discussions. They showed genomic instability in surviving individual fertilized stem cells. In the pre-implantation phase, they did a large amount of cellular radiobiology in fertilized ovaries, eggs. So these data suggest that there is some a stochastic process, but not only, it's not an all or nothing effect, it is it still is a stochastic effect. And the all or nothing, it's a question of the definition. What do you mean? That's a big problem. That all these distinctions are based on how do you describe it?
Yes.
How
yes.
do you see it?
Yeah.
It's not the whether yes or no, but what do you see? And so the evidence that there are, for example, carcinogenic effects in the pre-implantation phase, of course, that probably extremely rare, but I wouldn't just say by definition I rule it out. In particular, if you think of genomic instability. And genomic instability adds a stochastic element into any progeny of irradiated stem cells.
Klaus, good morning. It's
Good
Rafi.
morning.
I want to go back to the first question when you speak about mental retardations, and indeed our first hypothesis was that, let's say, with radiation we induce apoptosis that reduces the cell mass in the brain, and that would induce, let's say, the mental retardation. So, but yeah, with the time, it's still valid hypothesis, but it when we see, it doesn't mean having a bigger brain you are more intelligent. So yes, I am coming there. The female brain is almost
that's
half,
18th century,
and they are smarter.
Yeah.
Okay. Anyway, this is one thing. Any more? Yeah.
Of course, spontaneous microcephaly is one of the possible causes of mental retardation. That's the pediatric general rule, but it's definitely not the main. And if somebody has a small brain, mental retardation is not an inevitable consequence. So it goes together in some way, but it's not the main cause. Moreover, the definition of mental retardation is extremely soft. One can have some mental retardation and an IQ of 100 if the child has parents which really get the last reserves out of the brain. So education is an important factor to produce a good IQ, even in somebody who has deficits.
Yeah, but Klaus, this is one thing, but we found ways to measure, let's say, intelligence, but it's still subjective to me. Intelligence, there are different forms of intelligence. Not all people are equal in intelligence. So but and these are different, let's say, ways of brain functioning in terms of synaptic connectivity. And this is happen later in after birth, when all the synaptogenesis occur and when all the connection, and there where you see the high growth of the brain. It's postnatally, actually. Yes, exactly.
This is what I also mentioned yesterday, because it doesn't stop on week 15. It goes on until age of 6 to 10.
Exactly, it goes up to puberty.
We can debate this all day. This is a fascinating topic because we know that the brain, in the premature infant, for example, they have it's white matter development, and that's that connectivity. It's how much white matter. And now there are, it just came out in Nature that there are now these international atlases of normal brains from the premature infant to the 90-year-old person. And you can look at what is, quote, normal to compare to what is not normal. So we can have that on MRI, to compare. And it's about, white matter and aging. Yeah. Yes. Yeah. In color. All right, so let's move on. So you've got some notes on that and reference, and then thanks, Klaus. The next slide.
No, he's wrong.
Okay, so the third question is, can the threshold doses for malformation observed for animals be reasonably transferred to humans? I think we have the same problem, right?
I think one can never transfer animal data to humans directly, not the least because the time scales are so enormously different. And of course, we know there is a certain period where things matter. I usually in my lectures show, when I talk about this, thalidomide. It only works in a certain period, causing malformations. And there, the evidence is fantastic, much better than with any radiation, because there are so many cases. So it really is a question of days in human development, rather than weeks. And so we have to assume that when the signaling comes to do special processes, for example, start migrating also, but migration certainly is something which goes over weeks in humans. And therefore, the period is longer. And so the doses in animals can certainly not be easily transferred because the doses
Right.
Have because I think the time factor is also very important, and the brain is smaller, fewer cells are suddenly going off to migrate. I would never be confident to transfer doses from animals into humans. Also not in radiotherapy. We never do it there.
Well, if we're talking about mental retardation and neuronal migration from the germinal matrix, that is complete at the 34th week of gestation. So, but I think Rafi wants to say something.
Maybe I don't agree fully with you, Klaus, in terms of. I know you like it. Yeah, in terms of transferability from animals to humans, this I think we have just a bit to go further in our thinking. Sometimes, let's say, when I see in the pharmaceutical industry for drug discovery, all animals can, let's say, provide data that is used later on a human. So this is just has nothing to do, but here we are discussing the risk estimation. So, and so far for me, when I see all, let's say, the processes of brain development that are highly similar to human, I
Yeah.
think there is a way to explore and to use these data generated from animals to, let's say, use it for the risk estimation for human.
It is, I think we have not very convincing data in humans. We have very perfect data from your lab and others in animals. So we certainly start with the information from the animals, and then the next step is it compatible with the lousy data we have from humans?
You know, we cannot expose humans just
No,
like that.
we won't. We won't. We accidentally we have these, and
Yes, yes.
unfortunately we only have these data from Hiroshima. And these children were born and grew early, and early growth was in a situation of utmost social confusion. So we are not looking at radiation effects alone in Hiroshima, but that's the main data we have.
Mhm.
So it's a combined effect, and this makes it so difficult.
And then I think the ICRP, you know, which publication 90, which was it? No,
Not publication 90, yeah.
90, yeah, I think it was 90. Well, it had the same conclusion. They had a quote that said, we cannot be certain, have any certainty. So, okay, next slide. That was this, oh, sorry, mental retardation. How sure are we with the threshold of 200? I think we've concluded that pretty certainly.
The threshold of 100 is what is mental retardation? Is for example, in other so-called tissue effects, say cataracts.
Right. We know that
we say it's a cataract if a machine, the Scheimpflug camera, sees some tiny opacification, but the patient has no visual impairment.
Right.
That's
right. So
this is an effect because
right.
the machine sees it. In mental retardation, we have a very, very soft criterion, which is based on a multitude of social, occupational, learning and behavioral changes. So the whole system doesn't work. And so I would say whether there is a threshold depends on what do you describe as mental retardation? Is a decrease in of IQ of 3 points retardation, yes or no? It's a question of definition and not of facts.
Right. Well, right. So it's an artificial one, and it's one we're setting. So I think there are two issues with that question that we've already discussed. One is, first, we don't use mental retardation. We say intellectual disability. The second is though that it's,
that would you would not be able to apply this definition to the Japanese data.
No,
because they say they are so disabled that they have to be institutionalized.
They used severe disability, severe mental retardation for their very small cohort. But what I'm trying to say is that we now have in our society, right? I understand, Klaus. Let me finish. We now have better tools to both but with both imaging and other ways of our society of recognizing, like you were saying, cataract. So early cataract, we can define through different tools earlier abnormality, whereas 50 years ago we could not. So what I'm saying is we can define things differently. So I think that's a little outmoded.
Yeah.
So I think that's what I'm trying to capture in what we want to say. Yes.
Klaus, is Rafi again. So yeah, I would have loved to discuss again with you my data about, let's say, the neural tube defect that I showed yesterday about, let's say, when we irradiate animals at E7.5, we observe a lot of malformations just, let's say, at E18, just before birth. And one of the major malformation was about the eyes.
Yeah.
Microphthalmos and anophthalmos, they were quite high in rate. So, but there are some information also from Hiroshima and Nagasaki that they have shown, let's say, some eye malformations.
I haven't seen these data.
Ah, yeah. But this is, I find it quite interesting because actually if in another way, the eyes can be part of the brain.
Of course.
So this is, yes. So when we irradiated this special period of neural tube closure, so we affect dramatically also the eyes. Yeah, but yeah.
And so the problem is that we have data on only a ill-defined word, microcephaly, or 2 words, and severe mental retardation. But what happens is so complex that we have difficulties in applying the numbers which we were given from Japan from investigations 60 years ago to our knowledge today.
Sure.
We have data on criteria which were just simple, oversimplified 60 years ago. And now we have to, we don't have anything except your and your colleagues' data on what happens really in the brain of mice, and we are sure that the very similar things happen in brain on a slightly different time scale.
Yeah, exactly.
But can we use now the new data to interpret the old ones, and how do they relate to each other?
Yeah,
and this is a fantastic intellectual challenge, but I think it hasn't been properly discussed yet.
No, indeed.
Okay. I think in this case, in this situation, we about this, I think we both agree.
Sure. Yeah. Okay, but we have to sit a week together to solve this problem.
But in Belgium, with good food.
You're welcome. You're welcome.
All right, last slide for questions. Is there new information on deterministic effects after in utero exposure, such as after Chernobyl?
This is a question which I pointed out. There were many publications in sometimes even decent journals, and they were mostly on simple things like cleft palate. It's easy to see, and they are recorded in some registers. And with a little bit of intelligent mathematics, you can show that it was more common in those areas where there was a high fallout from Chernobyl, particularly in Ukraine and in Belarus. These data have been collected and published. But since they are not related to severe mental retardation and all these other things, and these skeletal malformations which are seen in animals, I have the impression that these data were too quickly neglected, and but they are read, and the anti-nuke community is using this to cause uncertainty in the population. I think we have to look at them, appoint a little small committee which looks at these data all together and say, are they individually or are they collectively worth taking seriously? I looked at some, they read well, but I have some doubts, in particular since the main effect which they describe is related to folic acid deficiency as well. And in a situation after Chernobyl, where there was a big hiccup of the society, social problems can have very strange side effects, like, for example, less care, the normal system of care for pregnant women goes down. So there are many things can happen in a very indirect way, and this needs to be clarified, because otherwise these cleft palates and other congenital malformations which have been described as being increased in certain areas in relation to Chernobyl dose, they will be with us for a long time, I assume, because they don't have any other information.
Yeah, I agree with you, Klaus. I think that sums it up quite well. There are these reports, well, they're feasible, but when you read through some of them, you wonder, you just wonder if they can be related to radiation exposure. So I'm in agreement with your summary there.
Klaus, yeah, you just give me another maybe idea I miss in my experiment with folic acid. So yeah, we see clearly with, let's say, supplementing the food with folic acid that we can reduce the malformations in mice, but we didn't test, let's say, the other way around, let's say, by reducing or removing folic acid from the food. That could even give additional information to.
I think there are so many beautiful experiments you still can do.
Thank you. I know that you can have many for me. Okay, the second or the third?
Second one.
Second. So we move to the next question. Is there enough scientific information available to integrate the risk of cancer after in utero exposure in the calculation of detriment?
This is, of course, what's the aim of this detriment inclusion? It means that you need one number, and that's the effective dose. Detriment is part of the calculation of effective dose. You have incidence, lethality, and detriment. Weighting the contribution of different cancers to add up the different organ doses. Now, detriment, radiation-induced cancer after irrigation in utero, certainly the detriment is high for the childhood cancers, although 90% are cured today. Even acute lymphatic leukemia is now a curable disease. But the detriment, the overall detriment to the individual is enormous. So I have some problems with this because we calculate effective doses not for the individual. ICRP has clearly said never calculate individual risk from effective dose. So in order to calculate the effective dose are used to compare different procedures.
Right.
And not more if you irrigate the whole population, including pregnant women. Although pregnant women should not be exposed to radiation anyhow. So they should actually be excluded. The embryo should be excluded from a being member of the public, which is exposed, say, to nuclear power plant around the corner, or which we don't have in Germany anymore, but they are around somewhere else. And then procedures in work, but pregnant women don't work in restricted radiation places.
Yes, they do.
And then the main thing is it's used in medicine to say how the effective dose increases because we have more machines and therefore more X-rays are taken. But in principle, radiological procedures should be not done in pregnant women, whatever the stage of the pregnancy is, unless the benefit from the X-rays even better than in a normal situation. So it's and for this, effective dose should not be used because that's the definition of the effective dose. It's the dose which the damaging dose for a whole population. But if you exclude members of the population on purpose, they should not go into the calculation. So it's a very difficult argument. I've discussed it with Jakob long ago, and we said it's for completely different purposes. It was introduced at a time when we were pretty certain that within 20-30 years all the electricity would come from nuclear power because they are so clean. It was different times. And now the detriment is part of the effective dose. And I think this is another work package for ICRP to define the purpose of effective dose And who is included in calculation is a pregnant woman, or is the embryo and the early fetus, or any stage of pregnancy included in calculating effective dose in a
And I think
pregnant woman.
I think that's the point, Klaus, because
Yeah.
when you look at the 2007 recommendations, the judgment made at that time that there was insufficient information
Yeah.
on whether there was a risk of cancer arising from in utero exposure. Since that time, in particular, if you look at adult cancers among the bomb survivors irradiated in utero, there's a lot more information. There's both incidence and just recently an update of the mortality data. So in my mind, there is now enough scientific information to include in utero exposure, which was deliberately excluded before, and that the level of risk, if you take throughout life, I mean, okay, there's childhood cancers, and there's still questions over the spectrum of cancers in childhood, but they, in comparison with the level of risk of adult cancers being predominantly a disease of adult life, of course, then they don't actually contribute very much. So I mean, in my feeling about the answer to this question is that yes, there is, and that the level is probably what is currently assumed for exposure of young children, because it looks about the same. Of course, there are questions to answer, like why is the mortality evident in women but not men? But I think that you cannot exclude any longer the inclusion of in utero exposure in the cancer risk.
But how to do it? You have to do it for the whole population. So how many women are pregnant at any one time? Say a few per thousand women. But then you have to put in the age. So it's 1 in 5,000 of all women between age 1 and 90. So, and then the doses, you calculate the dose, that's fine. But then the cancer risk contributing to the overall cancer risk, we have pretty good data for the risk of in utero for the childhood cancers. I think the follow-up will probably mostly come from Hiroshima. They are from RERF data, and they are not fitting very nicely together. So it is complicated. I think it's worth trying to do it, but not saying, yes, they have to be integrated.
Well, we'll see. I think we can make the recommendation from this
to
group.
look into that.
And Dominique has this. And I'll just make a note that we have a working party that Richard and I are part of to look at individual.
I will be very interested to read it sometime.
Yeah. Well, we're trying to look at ways to make the effective dose applicable to the individual patient, because there's been a call for it for a number of years by different groups within the medical community.
Yeah,
So,
they are used, of course, because they are so simple. The main reason to use the effective dose in the radiology is that the doctor tells us, oh, don't be concerned about this CT scan. The effective dose is the same as if you spend a month up in the mountains in the Alps, and this, you know, that does you good. and therefore maybe the CT does you good as well. This is the way effective dose is used in practice in medicine. And this is something for which it wasn't made. Always comparing nice situations to flying to to America or to exotic holidays regions. This is the same as the X-ray picture which we take. Effective dose is the same, therefore the damage is the same. And this is not applicable, and ICRP in the past has consistently said, never use it for individual risk estimation.
Yeah.
And why change this?
Yeah. Okay, next question. Is there baseline incidence data on congenital malformation available today for different populations? I'd like to address that. There are in the Center for Disease Control, the CDC in Atlanta, Georgia, collects data from two states, from California and from Georgia. Up to age 1, they do the congenital anomalies reported from those two states, which you know, California has a very large population. It has a population of almost 40 million people. So every year they send data to the CDC, and it's categorized, and it's searchable because I've done it for my own research, and Georgia as well. It has fewer, it has about 6 million people, and you can look for different congenital malformations that are detected up to 1 year. So it's pretty robust data.
Yeah, this is very nice. It's just the risk of cancer, which which I was talking about.
Well,
the baseline incidence. Oh, the next you are addressing next one. I think there. I was still thinking about the question 2 and not the question 3. Sorry, but I think we really need good data. The big problem is that they have congenital malformation in a family are a stigma, a social stigma. And this is something which may cause reluctance to, one has to be very good in anonymizing these data.
There's the big Eurocat registry here as well, in Europe, I mean by here. Helen Dork, I think, still looks after that. She did when I was interested in this. So there is that big database here now as well.
I've never used it, but I know it exists.
Yeah, there is all. Yeah. Now I found it, Klaus.
Yeah.
And this is also maybe data that we don't use much. This is from the Ukraine region of Polisia, and that has studies that has been done by Werteleki. And they are showing also microcephaly, neural tube defect, and eye size defects. There is there where the eye size defect was, let's say, they speak about microphthalmia and anophthalmia.
We also need to look at our own summary slides, which I want to thank Amelie and Ludmila for putting together from the bad writing. So can we go back to the beginning, to the very beginning, top of the first slide? Yep.
That's a nice slide. Better quality. Everybody. Mhm.
Okay, so second slide. That's our, these are the presentations that were given and the titles, so the author title. And then next slide. Oh, okay. And that's my topic. Next slide. Okay, next slide. That's just the main thing. Okay, next slide. Oh, those are my research questions that I thought we should
Mhm.
address. Okay, next slide. Okay,
Mhm.
okay. Okay, next slide. And these are your results. All right, Homer. Okay, and next
Mhm.
speaker is Rafi. Your title. 1, 2, next slide.
Yeah.
Okay, then
Oh,
this
the
is
eyes. Yeah.
about, well, eyes
Skeletal.
and related, right?
Mhm.
Really, it's midline defects. It's,
Mm.
to me, it's, yeah. Next slide. And conclusions. Okay. Next slide.
Mhm.
Next slide. Okay, next slide. There's a lot of information. Okay, and this is Stefan. Next slide. Epigenetics. Yep. Next slide. Next slide. A lot of information there. Okay.
Mm.
Okay, next
Mm.
slide.
Yeah, I remember that.
There's a lot. Okay, next slide. Oh, go back. Sorry.
Mm. Mhm.
Okay.
Mm.
Okay. 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 And then Klaus. Okay. Next.
Mhm.
Yes, right. It's very, yep. Okay, next.
Mhm.
Should we record the effects?
Yeah.
Yep. Okay. We've seen that more than once, right? That,
I always show this slide because it's not often published. It gives you such a visual impression of
you're right. Yeah.
what's really happening.
Yeah. Okay, next slide. And this one too, actually.
Yeah.
You're going to show that the next thing. And that one and the.
But again,
yeah.
just come back to this. What I want to stress in the previous one.
Okay, go back one. Yes.
The risk is given at 1 gray, and so you can from these data get any sort of threshold or whatever, and particularly the 0.6 gray point, of course, has a huge range of doses. So the threshold which you put into this is very uncertain. And the threshold is more or less extrapolated in a sort of linear way. Otherwise, we don't see anything up to, yeah, the point is at 0.2. We say if we take it at 0.3, but you see that the point at 0.65 is based on 3 cases with huge error bars.
Yes. Yes.
So the threshold, whatever you say, is not scientifically based. It's based on the taste of what do we want to have. We want to have a good, solid threshold, which is so high that we don't ever reach it in diagnostic radiology.
In real life, exactly. And
In
so,
real life, it's
Yeah.
radiology is not a problem. What do we need it for? The only situations I was asked to go into this, and quite often, is there any reason to advise the woman to go for an abortion? The indication or for a recommendation for abortion is the only use of this graph. I hope
Right.
you are aware of that. This
Oh, yes.
graph decides life or death of the embryo by the doctor who does the abortion.
yes. Okay,
And it's
next.
based on
Oh.
the interpretation of this graph.
Oh.
And here, okay,
Yes. Yes.
it looks nice and linear, but still the confidence limits and the credibility of the data, we don't have any other data. That's a problem.
Right. Right. Okay, then that one, and then the next slide. Those are your questions. That's good.
Mm.
Next slide. Highlights. Those are the things that we all took away. We've written down. Yeah, that's the messy writing I had, but this is the very nice writing by
Mm.
our rapporteurs. So that summarizes
Mhm.
our thoughts so far. And they're just a number of points,
Mhm.
right? No, well, it's just a,
Mm.
okay.
Mm.
So did we capture them all? We said review
I think so.
the 2013 NCRP report. What's happened since then? We need to do that literature review. And a number of other.
Maybe the problem of confounders. Some possibilities of mitigating it, the folic acid studies. On the other hand, that the Hiroshima data are strongly influenced by health effects on the mothers. And I think this should not be completely neglected,
Right.
because the social trauma, and in particular the severe effects of particularly the heat flash. And this is the nasty thing about it, it's strongly correlated with dose.
Mm-hmm.
Somebody who was exposed to, say, 1 gray or 2 gray, and there were some babies born from that, their mothers, if they were not very lucky in a very solid home, were probably burned and had, and say 10% of body surface burn causes a shock-like syndrome. And this certainly is not good for the baby either.
Right.
So there are so many confounders which have never been addressed.
Right. So that question kind of fits into the, are we missing health effects that can also impact on the well-being, even though they are
Yeah.
not related to mortality? You're bringing
Yeah.
up a point that I think we touched on.
Not necessarily
yes.
mortality, but
Right.
indirect damage to
Right.
the child. So some word about confounders
Yes.
uh,
Right.
would be useful. I never thought of that for a long time until it just happened to me when together with my students I saw movies on Hiroshima
Right.
and saw the people.
Right. A lot of good documentaries. How about the next slide? Let's see. The number of things that we talked about here. One of the things that when I reviewed literature, and I'll ask you this, Klaus, I found that there were case reports of women who had radiotherapy in the 1960s. I brought this up
Could you
before.
go closer to the
Yes, the microphone. There were women who had radiation therapy
yeah,
of the abdomen and pelvis for
yeah,
lymphoma or cervical cancer, and they were pregnant, and the doctors thought they would abort, and they didn't, and they had normal gestations and normal babies.
yeah.
And some of these women had up to 8 gray of exposure to the fetus.
Yeah, two parts of the
gray.
fetus.
Yeah, I mean, it's incredible. Estimated
If you look at old textbooks of radiotherapy or old volumes of radiotherapy journals, they are not rare. But these data are usually very inhomogeneous dose distribution. We have no idea of the position of the baby in the womb, so we have no idea about dose distribution and about which organ or which part of the embryo got which, or fetus got which dose. It's for the embryo, it's not a problem, but for the fetus, it definitely is. And very often, the most often reported, as far as my experience goes, effect was that there are extremities, the growth of organs was reduced. It's size difference.
Right. Well, and we saw that with some of the, the reports from last year of the Chernobyl birth outcomes of smaller babies, and the Sugiyama paper of smaller babies, smaller heads on average. So that's interesting to me.
Yeah. But is the size of a baby related just to growth, or is it just to the energy supply to the mother, food supply to the mother?
Well, that's a good question. I don't know. I mean, I know that the reports were there's a dose effect for growth, for fetal growth, at least in the animal studies.
Yeah. So the problem is that in all these situations, dose, radiation exposure, and social, say, deprivation or whatever, and hunger, clear, simple hunger is often correlated.
Right.
And so one doesn't know what to attribute it to.
Okay, next slide. I think those we did. Can we go down to the bottom? Okay, we have some pictures of us. Let's see, next slide. I think that's it.
Oh, that's a nice picture of you.
Okay, so we don't have pictures much of the group online. We just have your names there. Oh, previous slide. Yeah. Okay. Yeah. So Okay, so we'll get rid of the slides and
Mhm.
we could do a Iggy and Ahmed, if you could we could get a picture of you. Ah, I know, now I know.
Take the glasses off, Naomi. I want to see your eyes.
Yeah,
Yeah, you look much better.
yeah.
Screenshot?
She's been putting it on the slide. The young people that can do great things with it. Thank you. All right, Eric, anybody, thoughts? Pass the microphone. I mean, we have time to, yeah, how about Ahmed, Iggy, thoughts? We haven't heard from you. What is your research right now? What? Iggy. Oh, Iggy, what research are you doing? Yes, what is your research right now?
Right now, we are finishing up on the transgeneration since we finished the in utero. And now we are exposing at different ages from birth to juvenile ages, also at low doses. So different ages. That's what we are doing right now.
Mhm.
And we are also working with Singapore, and they are doing in utero exposure plus 30 days at 20 milligray, 1 milligray, and 100 milligray.
Okay,
But still, it's the animal study is still running, so we don't have data yet. They're planning to do behavioral testing, but I think it's not going very well for them in Singapore. But so we don't know yet. It's supposed to finish in September this year.
great, great. And Ahmed, what about you? What are you working on?
Yeah, I'm just working on old samples from many of the colleagues there know me as it. I'm working on cardiovascular disease, and I have samples from the Apoi mice from IKI facility after almost 300 days exposed to very low dose rate, and then we're looking in the proton profile of the heart in these mice, and we want to see that how similar is to the acute or how different is from the acute exposure. It's very promising data, but as I saw the proteomics data recently, I received them.
Wonderful. How about
Yeah, just maybe again a point that we discussed it yesterday.
Maybe I can say what I did.
Sorry,
what I'm
yes, go
doing.
ahead.
I'm teaching the.
You are still doing
MSc
experiments,
course.
Klaus.
Sorry?
You are still doing experiments.
I don't do experiments, but I'm teaching in particular also several sessions of human radiation genetics, which is based on the information and all the publications by Sankar, who died a couple of days ago, and also in utero effects and radiotherapy effects, side effects of radiotherapy in children. These are major issues which I'm teaching on the MSc level. And this is a great challenge for me, and a fantastic opportunity was that I could participate here and learn a lot. By teaching, I learn more than by
Sure.
doing experiments myself.
Sure. And we are still learning a lot from you, Klaus. So just one point, a question that arose yesterday, but I didn't answer about accelerated aging. So it has been discussed several times, but I can say here, at least from all our animal studies of in utero exposed, we, for some experiments, we follow them up to 24 months, which is, let's say, the life expectancy of mice. And we didn't see any difference in terms of aging of irradiated animals compared to the non-irradiated ones. Yes. Whole body irradiation, yeah.
Mm.
The problem, Rafi, with the is here also you have a difficulty with the definition about the aging. I think the broad range of the pathology associated with the aging and it's simple oxidative stress to any morphological pathology, and it's difficult. I think that soon, very soon, the definition of aging or any aging related diseases would be changed, and then perhaps you will include all your observation showing the initiation of aging as well, as it can be well included.
Yeah, I find that really interesting because children still undergo, sadly, whole body irradiation prior to stem cell transplant for the really nasty neuroblastoma cancer. But it is cured in 25% of children in developed nations that they have the access to these very intensive treatment. And also for stem cell transplant and leukemia. But Klaus, it's 80% of children that are cured of cancers, pediatric cancers in developed nations. 90% of leukemias are cured in children. Of course, that's not so good in adults. Leukemia is bad in adults, very bad. So Klaus, I wonder if you could be a consultant for our task group, because I think it'd be very valuable to have your input going forward. We would really appreciate it to have your expertise going forward.
My expertise
Yes.
is not a practical one, but I
No,
was the radiobiologist in the first case of childhood ALL who was treated with total body irradiation in Neuherberg and was cured. The first case in Germany, probably in Europe. And since then, I've been very much interested in this.
Yeah.
And at the moment, we have 3 cases. One is a 3-year-old child with ALL who is going to be treated with bone marrow transplantation only in a recurrence because she's doing well. I have one who is a 30-year-old man, has had total body irradiation, cured, back to work, and a 65-year-old woman with ALL who is going to have her bone marrow transplantation in 2 weeks. So this situation is very close to me emotionally and historically. And I was cooperating with somebody at BFS who had the registry of late side effects from these total body irradiations. So the data out there, I'm very interested in this. And
yes, I've seen
my historical
effects.
dinosaurial memory will help maybe.
Yeah, I've seen some really interesting effects from children with that whole body, even in the hand, you know, the osteochondromas they get from whole body, you know, I don't know if you've seen that.
No.
Anyway, the bone cartilage changes. So it's curious. So I don't know if anyone else, we can stop and go early to coffee, right? We have The next session, or we can go around the room and talk about what other people are doing.
Going on.
Comment about this summary presentation. Now I just updated slides with Eric's and with our pictures. So we have 40 slides now, and however, it was just timing. No, it's good point. And so we will go. That's why I was giving you words that you quickly speak in the summary, in your slides. When I will pass in your summaries, just maybe quickly do it very quickly, okay? Because we have like 15 minutes and we'll try, I think, at least in 20 minutes to put everything. Okay, good. So, or if not, we can. Okay, we can.
Well, I don't get much chance to do much research these days, actually. So, but I guess we're trying to get the whole genome sequence study going in the trios. That's one of the main projects with the stakeholders. And then I'm also working a lot with our ITD section on trying to improve our data infrastructure. And so we can better assemble data sets and visualize data sets and try and improve our ability to design experiments. And then the approval processes have gotten burdensome at our institute. So we're trying to come up with electronic flowcharts to do this rather than on paper and try and improve our throughput. But that's what I'm working on at RARF, and I appreciate the opportunity to come out and meet all you guys and contribute a little bit. So here we go.
Yep, so I think I've shown mostly. So yeah, so what we are focusing now, besides of the radon issues, is how tissue level interactions can affect, minimize, optimize mutation rate in cancers.
So I'm new to this field. I'm doing my PhD, and my topic is atmospheric dispersion modeling and public dose assessment. So I'm here because we are trying to find a way to compute the fetal dose in public. And I'm just really happy to be here and hear all of this information and new findings. Thanks.
Yeah, for me, I spent already almost 20 years on in utero exposure. But I thought I did my contribution, but each time speaking with Klaus, yeah, there are many things to to add again, but in the recent years, I move more to, let's say, postnatal exposure and the young animals to simulate, let's say, young child exposures.
Just say, okay. Well, I was used to work in post-accidental recovery and better preparedness to nuclear accidents. Yeah, with Elizabeth Cardis and TS Global. And so I also related this holistic approach for taking into account socioeconomical, psychological issues to be taken into account for policy making and decision making, and with engagement of stakeholders and general public, etc. And here I'm happy also to work on this group. I a little bit touched in Nutra, as I showed in my presentation, this Nutra study from Belarus, but I think we can contribute from different point of view, and happy, and think we will follow. Thank you.
So I also was working on huge accidents like nuclear and radiological accidents in Brazil. We got 3 hospitals prepared to emergency situations there, but regarding to internal dosimetry, from internal dosimetry. But now I'm developing a biokinetic model for pregnant women to assess embryo and embryonic and fetal doses due to intakes by the intakes of radon by the mother. That's what I'm doing.
So it's okay like that? Yes. So I was especially working on uranium exposure in the past in the post-accidental situation, and interested by the issue of population living on contaminated territory. So currently, I'm always working on result that we produce by our last study based on the contamination of rights, and we monitor mainly metabolomics effect on 3 generation after in offspring, and we try to compare effect on different physiological system, and now I'm coming to present a new plan based on the internal contamination of low-dose cesium. It's chemical radiation compared to uranium, who is most chemical than radiological, and it's very different. But we decide to reduce our study to focus exclusively on the first generation F1 because it's a huge and expensive study that we want to do.
Thank you. So I'm doing a lot of the ICRP Committee 3 work, which involves organizing the task groups and these workshops, and writing up the task group documents, which involve optimization in medical imaging. And we're just about finished with task group 108, which has 2 parts. One is on general optimization in digital imaging. The other is on more specific guidance on the imaging for radiography, CT, fluoroscopy, and interventional procedures. So the first part is supposed to go out for public consultation any day now. The other one we hope to have out by the end of the year. And the other task groups are related to ethics of radiological protection in medical imaging. And that we hope to have out by the end of the year as well. So that's been a long, that's been 4 years that we've been working on that. And there's a presentation here by Marie-Claire Canton on what we've been doing to create case scenarios for people in the RP community to use for teaching purposes, and also to think about when the evidence is lacking, what they need to think about in terms of values to use for how to create solutions when there's conflict within their team or conflict with the patient or patient's family about what to do to solve the conflict, for when to use the medical technology or not in medical imaging or therapy. So that's just an example, but there's some other task groups that were doing literature reviews and write-ups.
Well, I'm finishing off some studies, which have taken a lot longer than I've anticipated. One of them, one of the reasons being of actually being able to link data these days between databases, which seems to be appallingly, appallingly stretched out to what it used to be. Other than that, I'm just bringing together evidence in a load of reviews for ICRP, UNSCEAR, and and in general, really to review evidence for those bodies. So, which keeps me busy. By the way, when we, sorry, what? What? No, all right, okay. I was only going to say when we meet again, it will be for the ERPA radiobiology session, which is in lists, which is up the end there. So we're all going to be in list, the room. I don't know what's going to happen there.
All right, hopefully you all can listen in that list room and hear these 6 presentations. And then we'll come back and it'll all be together. Well, all the groups, A, B, C, D, will convene and you'll hear summaries. Great. Thank you.